Fentanyl is much more potent than heroin, and the danger is that it causes severe respiratory depression, and people are dying from it. And it's in most of the opiates that we're seeing on the streets now. So if somebody thinks they're getting hydrocodone or oxycodone, they're probably not getting it. They're probably getting fentanyl, pressed fentanyl. I'm hearing stories of all kinds. I've heard stories of patients coming in saying their marijuana was laced with fentanyl. I don't know if that's really true, or I think probably a lot of these cases are in where they're packaging and distributing it, that there's probably cross-contamination. But certainly I think a lot of things that are advertised as one substance are actually pressed fentanyl. Yeah. Well, without medication, people are going to have a really, really hard time of it. They're going to have cramping, sweating, vomiting, body aches, pain, restlessness, agitation. So what we use in the detox process for opiates, including fentanyl, which is mostly fentanyl, is a medication called Suboxone. It's buprenorphine and combined with naloxone. And what buprenorphine does is it is a partial agonist / antagonist, meaning that it binds to the opiate mu receptor at a high affinity, higher than some of the other opiates, and you get a partial response. So it basically reduces the cravings without giving so much of a high. So what we do is when patients come in on opiates and fentanyl is that we start the buprenorphine protocol, which means that we're following their clinical opiate withdrawal scale scores. And there's a number of different variables that we grade from 1 to 6. And based on combining those scores, we get a number. To keep it simple, basically 8 or above of a CAL score is where we would start protocol. Now with fentanyl, because it has a longer half-life and it doesn't show up on your normal drug screen, your routine drug screen, if they're using fentanyl, we would typically wait 24 hours to start the protocol. And so what we do is they get a particular dose of buprenorphine, 4 times a day, 3 times a day, 2 times a day. So we gradually taper them off, and we're watching their withdrawal indicator scores. And then it's also up to the individual patient in our discussion with them. Some people want to get completely off opiates. Other ones we're going to get them established on medication-assisted therapy, meaning that they're going to be using a baseline dose of Suboxone to keep them clean. As you probably have heard of methadone, and it's kind of analogous to that. The problem with methadone is people have to go to the clinic every single day to get their dose. That's really hard to do if you're working or have kids or family. They also have to be tested and see if they're drinking or using drugs before they can get the dose. And if they test positive, they're not going to give it to them. So there's a lot of barriers to treatment with that. That's really variable. It could be 4 or 5 days, maybe up to 7 days. But everybody is different, and so that's why we don't just lump everybody together in the same category. We use the same protocol, but everybody's numbers are going to be different as they're coming off. So we treat each case individually. Well, all the health complications that could go along with it, and people would certainly feel terrible, but you're not as likely to have things like seizures with opiate withdrawal. Now with alcohol withdrawal, that's a big concern. If they're big drinkers, and seizures will kill you. Even though we do have medications to try to keep the detox process as smooth as possible, it's still not going to be pretty. It's still going to be painful, and they're going to go through some difficult times. But we have the medication there to try to make it as smooth as possible.